Good morning, everyone.
Morning.
Morning.
Good morning. I recognize those voices, Ryan and Heidi. Okay. So it looks like we only have about 81 students so far. Give it a, I guess we could get, class starts at 9:30, right? Not 9:35 anymore. So,
Yes.
yes, okay. Perfect. Thank you, James. 9:30. All righty then. So we're going to start with, these are my last few lectures I have for the semester. I'm really excited about being done. It doesn't mean that I'm not still available for questions on my content, or if any student has questions that they want to shoot out to me or meet with me for questions. I'm going to try to hold a study session next Monday in the morning before exam 4, if anybody would like to join. And we also can review content for the final if you're all set with exam 4. So what we're going to talk about today, I tried to break them up into separate little PowerPoints just so it wasn't so overwhelming for you, but we're going to talk about professionalism this morning, and then nutrition contains information about obesity and bariatric surgeries. And then another content we're talking about is self and eating disorders. So the three go hand in hand, and professionalism is kind of a little bit different topic. But it's something that we talked about freshman, I would say freshman, the beginning of class when you first started about a year ago. Can you hardly believe it's been a year? When you guys were novices, first day, I think we talked about professionalism. What does it mean to be a nurse? And how is a profession different than than having a job? Now we're going to build upon that and talk about accountability. And I think you guys had some discussion with another professor about the nurse who gave the wrong medication and was found guilty after the patient had deceased. So hopefully we'll have a little bit of an interactive conversation. This also talks about different memberships and being part of different types of, I can't even think of the word I'm trying to say this morning, groups or clubs. And so we're going to go a little bit in depth about not union. I'm thinking about like the NSNA. We're going to talk about NLN, the National League of Nursing, American Nurses of Association, different types of nursing organizations. That's the word I'm looking for, organizations. So some of the things that you're going to, we're going to cover today is about the nursing profession and how can we promote accountability and socialization of students to the profession. And that's part of our job as instructors, is to help you to socialize, help you become professionals in your role. We hopefully do that by, modeling good behaviors, providing you with feedback. Okay. So accountability is making sure that we are accountable or answerable or accountable for things or tasks that have been assigned to us. And we are also accountable for things that we delegate to nursing assistants. And one of the things it says is we're accountable for our own actions or non-actions. So can somebody give me an example of what an action we would be accountable for? A medication error. Exactly. Yep. Given meds. And a non-action. How about a non-action? Delegating out of the scope? Yeah, asking somebody to do something. Not given meds. Exactly. Good. So if a patient falls, right, we forgot to lower the patient's bed. We forgot to put up the side rails, not following protocols. Exactly. Those are all good examples. So we are responsible to work within our scope of practice, and perform duties only within our role. So, say a patient needed a chest tube and you saw it done, or somebody says, "Hey, come help me insert this chest tube," and you guys have not been trained or you are not licensed within your profession to do that, and something happens, you can be held liable for that. Okay. So we have to make sure we function within the accepted standards and the standards that have been set forth for us as nurses. And in order to do that, you want to make sure you look at what are the standards of practice of care and what type of organizations set these standards or guidelines that kind of guide or help us to know what it is that we need to do. Okay. So I put a few links to the Joint Commission, the American Nursing Association, and the National League of Nurses. And you could, the Joint Commission, everybody seems to know, they get scared when the Joint Commission comes to visit the hospital, right? Has anybody been to a facility where the Joint Commission has come in for a review? Yes. Yeah. Okay. And um, James or Sandy, does anybody want to share what it was that they were looking at, or what did you notice about the visit?
They kind of look for everything. So they like break down departments. So a couple of days they'll do nursing, a couple of days they do like dietary, they do everything from like admin and in between. But
Mhm.
like even when they're not looking at you, they're looking. You know what I mean? Like they're paying attention to everything, call lights, how you're talking, what are you addressing in the hallways, who's around, who's listening, med pass. They're doing everything pretty much.
Yeah. And they ask questions and stuff, right? And
Right.
it always makes me laugh, because when somebody says, "Oh, the Joint Commission's here," everybody scampers like little mice, right? Going to tag their IV tubing, going to lock doors or do things that we should be doing every day. So that's where it gets a little hairy, is because you should be practicing to hide. Yeah, hide in your patient's room. They don't want, a lot of times some facilities, when they know the Joint Commission is coming, they ask our students not to come to the facility. um but I've been to facilities where they've been fine with having student nurses there, and students are really good, that as long as we show them what it is that they need to know, is that the state, um even if you do things properly, it's nerve wracking. I definitely agree with that one. But they're coming to make sure that we are upholding standards for our patients and in the hospital. Okay. All right. Following to meet the standards that are set forth for us puts us at risk for liability. That's why a lot of you, definitely now as a student, you should have a student nursing insurance. And definitely when you exit the nursing program and become a graduate nurses or registered nurses, you're going to want to make sure you have your own professional nurses liability insurance. The hospital, the hospital says, um, that they have insurance and they will protect you or cover you. But I feel like it's like a Johnny coat, they're going to cover you only so much, and you want to make sure you cover everything. And make sure that you are able to justify and do what you have to do. We work very hard for our license. We work very hard for the our house or whatever our personal belongings are. We don't want to have to lose that. And now it's even scarier for nurses, as we can be found guilty and actually have to serve jail time for being human or making a mistake. Okay, did I skip? Okay. So what makes us a difference from a novice nurse to a professional? We will give you guys, and you guys are obtaining a body of knowledge that will help you to make good, sound clinical judgment or decisions that will help you to work in a safe way. Um, we teach you how to provide a service to your patients. We teach you about the different codes of ethics, and you want to make sure you know the code of ethics. And I believe you guys sign each and every facility's code of ethics when you go from one clinical site to the next. And that's telling you how we should behave, and what type of beliefs and stuff like that. Autonomy, you learned to be individuals. Um, and then we also help with professional organizations and transitioning into a professional nurse. And we talk about making sure that we become members of nursing organizations. And we have several students now who are members of the NSNA. And I'm going to ask them to share some of the things that we have done this past year, if they don't mind, when we get to that slide. So, what are some concepts related to accountability? You can read them. They're on your little cards. I see everybody pull them out each day at clinical, and that's great. So we're starting to see the connection between the two. But, I think some of the big ones is making sure that safety is there, because we want to prevent any type of injury to our patient. Socialization is learning how to become a member of a group, fit in with the societal norms, following the social rules of um, the relationship. So that's basically the same thing that you guys are doing now, as you learn to become nurses. We are teaching you how to fit in right with the nursing staff, to try to be part of the group. Does anybody feel a difference from your first semester to this semester, being part of the team, or anybody still feel? For sure, yeah, there you go. Anybody want to share about that experience or how you felt about socialization or the role? Oh, what
I
I've
think
seen.
that,
Oh,
um,
something I share.
sorry, I think it's um, very evident in the clinical setting.
Hmm.
Um, if your patient is needy and someone else's isn't, they're going to come help you. Um, like, I had a very needy patient one time, and Jonathan's patient had been discharged, so he came and spent the afternoon with me, assisting in providing care, and we had to do a straight cath and some meds and all kinds of stuff. So it's like a sense of helping each other as well as the patient.
Correct. Yeah. And I think what you're talking, what you're saying is about it becomes teamwork, right? And collaboration.
Yeah.
And one of the things I was also, you're becoming a team, a cohesive with your clinical group, but you're also becoming a part of the team within the facility. I see it, initially the students, they're new. Nurses tend to say, oh gosh, these guys are in the way. Here comes the student nurses again. Oh, they don't know how to put the blood pressure cuff on, and da 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 da. And they don't necessarily often nurture that. But by the time you guys are now in this semester, I see the students, I'm going to go grab the vital signs, and I see that you're short staffed. We're going to come and help out and take that on. And they say, oh, great. These guys are helpful. And they come. And the same thing with, for the majority giving report. Initially, they don't want to give report or be bothered. because they don't see the benefit in it, which is unfortunate. But as you start to become more of a help to them, right, they're like, oh, great, I got the student nurse. They're going to help me with meds. They're going to help me do this. And that's going to make my job a little easier. Of course, I'm going to go talk to them. And I see that you also learn to, I think somebody mentioned about speaking with the patients, you become more comfortable. You learn to talk the talk. You learn to talk the talk with the nurses, interact a little bit with the doctors and other healthcare. Yes, they are instantly much more helpful. Yes, exactly. And I find that funny that, they don't want to help from day one, but when they see that there is some benefit to that, that they are very receptive. Okay. All right. So you want to learn about what are the norms that are set forth for us. We want to learn how to interact with different situations, how to establish goals, and develop appropriate behaviors for ourselves um, as well. Right. The big thing about socialization is a mutual collaboration, and that's where I talk about you say the teamwork. You want to be able to support one another, and it's unfortunate that the culture isn't necessarily that of supporting each other as much as you would think that it should be in a caring profession. You often might hear that how nurses eat their young, the new nurses. And the big thing we'll talk about in the nursing shortage is how this impacts the patient outcome. All right. Nursing educators, they help you guys learn professional values. So sometimes you don't want to hear our feedback because it might not always be positive. But sometimes it is what it is. We have to turn around and help mold students because it is expected that you don't have this set of thought process because you haven't worked as a professional nurse. So we are turning around and helping and training you. Okay. The NSNA is a club that has, nurses can sign up for. I believe we have 35 members in our current two classes who belong to the National Nurses Association. We have three of your classmates. I don't want to embarrass anybody, but you guys should know them now. They've been working very hard for you. Autumn Burke is the vice president. Heidi Allen is the treasurer. Secretary, and Alexis is the treasurer. And so we meet regularly to accomplish some goals. They've actually just went to a trip in Utah. Would any of you guys want to share a little bit about what we've done this year and in hopes to get some students to come next year and join us as well now that you're seniors? You'll be seniors. If you pass. Oh, I'm gonna be positive. I want to see everybody everybody there. So the
Quiet, Ryan.
uh,
So, the student club, which, by the way, all of you should join because it's fun. But we do lots of different things. We were the ones that sponsored the blood drive back in February. We collected food for the on-campus food pantry. We collected toiletries for the hospitality center in Waterbury. We help with the pinning ceremony, which, by the way, we still need volunteers for if anyone's available. So there's a lot of community service aspects to it. There's also a lot of scholarship opportunities and networking. So four of us and Professor Anderson, who's a senior professor, just went to Utah for 5 days And they had all different kinds of breakout sessions and a Red Cross disaster preparedness session. So there's just all kinds of different opportunities, and you can be, involved in any or all of the events that we do. Um, so it's worth your while. Um,
I was gonna say it's fun. I think we have. I mean, it's it's a lot of work, but I enjoy being with you guys, and it is a fun and interesting part of it. Is the one part of my job that I find not the only part. I'm just saying it's a part of my job that I find um, to be something where we have fun, where we can laugh and enjoy each other and get to know each other as well. And the club is consistent of seniors and freshmen this year. So the seniors are learning more about leadership and mentoring the freshman students. And we're building more cohesiveness between the two levels, which hadn't been that way. It's always been an individual club for each level. The one thing I want to mention, I think it's after exam 4, right? We're going to be hosting a bake sale and a raffle. We can't call it a raffle, but if you donate a certain amount of money, you win a chance to win an item such as a stethoscope or some things that we have earned from the freshman sale. So the incoming class is now going to be coming in, and they're going to be buying items just like you did, and a percentage of that profit is going to come back to the club again, which will help with funding different things. We've done scholarships, which two students will benefit from, and a lot of different things. So I hope everybody will consider joining next year. If they have not, you also can still come. Our meeting is going to be next Monday, the Monday coming up at 1:00, 1:15 in Teams. If anybody wants to, come and see how they can help with the pinning ceremony or different activities or get involved before the end of the year, that would be great. Just shoot us out an email and we'll make sure you have an invite. And thank you, Heidi, for sharing. Okay. So what's changing? The way that we have to be accountable for. There are shifts now because of healthcare regulations, what they will cover, what they won't cover. So a lot of the demands that they put on the facilities actually makes us have to be sure that we are accountable for our actions. If you stop and you think about that straight calf that somebody was talking about inserting, um, two nurses have to be there, or we have to make sure that it's done correctly, that, we do it under sterile technique. Because if that patient develops a urinary tract infection, the hospital is going to be accountable for that, right? And that means that may not get reimbursed from the insurance. They might not pay for the increase in the time that the patient's there. So that, helps impact how we have to, or actually molds or change how we should be performing. You also see that the rise in healthcare is going up, and that impacts it. Consumer demand. Um, could patients nowadays can read all about the ratings of the different hospitals. They have many different providers that they can choose from. So you have a choice whether you want to go to Yale, whether you want to go to um, Hartford Hospital, if you want to go to Charlotte. You have a lot of choices, and a lot of the information about the ratings and stuff is available to consumers. So they're going to do some research. If you're going to go have an open heart surgery, you better believe that the patient is going to go and see who's the surgeon who has the lowest infection rate, who has the best outcomes. And they can also get a large body of knowledge from the internet, which we didn't have before. So, they are more informed. They ask more questions. Therefore, we need to make sure that we are just as informed as they are, and we stay current with our information. Okay. All right. There's a lot of different changes. We talk about evidence based practice when we talk about becoming a professional and being accountable. We have to make sure we are using the best practices available, and make sure that we are competent with in our practice. Okay. Trying to see what's you need to make sure that you know how to use online charting. I mean, for you guys who are just coming into the profession now, all you know is that a medical record that is electronic. Those of us who might have worked in healthcare for a long time, such as myself, I remember charting on paper, and having to learn how to, if I make an error, cross it out because we couldn't erase things, and everything now is so different. And so you have to be able to keep up with the times and learn how to use the technology. Your job is still using paper? Is it a nursing facility, like a nursing home?
My nursing home is EMR, but my assisted living is all paper. It's crazy because you have to transfer everything to 3 different places just to get it, not including your note and all that stuff. So it's a lot.
Yeah, and that's with the like the electronic medical record. It's so great. If a lot of the facilities are now, using Epic, so they can talk to one another. If you go to Midstate and you go to a facility that's connected, not, maybe Hartford Hospital, you don't have to give all that information over and over again. The healthcare providers have access to that. They can see, oh, this person has been in the emergency room for the last, 6 times in the last few weeks. Something might be going on. So it was easier for people to kind of, I don't know how to say it, but to manipulate the system. Say they needed pain medications, or somebody who had of a child. I think we talked about abuse. Oh wow, I'm going to bring my child to this hospital, for this injury. Then next week, I'm going to go to a different one, so they don't see that this child keeps getting bruised. Now you can see that. So I think it also helps with patient safety and patient outcomes as well. Somebody had a comment there. I didn't catch that one real quick. You definitely, yeah, streamlining. Exactly. Okay. Telecommunications is big. There's so many different roles now that you can do as a nurse. We not only learned how to do this, Zoom and different conferences for making it possible for you guys to continue on with your education. You see a lot more medical doctors offering medical visits over the internet, which is wonderful for especially our homebound patients. Um, you don't have to, there are some limitations where you can't put your hands on the patient, but there are ways to get around that. Like with home care, they have a way that you connect to nurses. Your vital signs are uploaded, your weight can be uploaded, you can do EKGs. I know I got my dad one of those cardia mobile things, because that's one of the things the cardiologist couldn't do for him, was to see what rhythm he was in with his atrial fibrillation. We were able to buy the card, and with two little presses of his fingers, we can obtain an EKG, and I can send it right to the doctor. So technology is amazing, and it's really become very, very helpful. Okay. You want to make sure that you read in the book about the different types of legislation, the different, this state board of licensures, who gives you your license. What are some of the rules and the regulations that you guys have to follow? Okay. Patient changes the Patient Self-Determination Act. All competent adults must be informed in writing at the time of admission as their right to accept or refuse medical care and to use advance directives. So you will see that every time you go to a facility, they have to sign a sheet that they are agreeable to, be treated. You also sign out they're agreeable to bill your insurance. And so it's important to know what laws are in place that also guide us with how we have to perform as a nurse, such as HIPAA. We can't just disclose information to people without their written consent. We have to be very careful, and it's can be challenging because a lot of times you have a family member coming in to ask questions, and if you don't know who they are and they're asking a lot of questions, you have to make sure that you can give them that information about the patient. That they want that information to be shared. Okay. Other big thing is the nursing shortage. We see um, nursing shortage kind of happen in waves. When I graduated from Naugatuck Valley back in 2000, I could get a job in any facility that I wanted to, in any specialty because they didn't have enough nurses. Then we start putting out more and more nurses. Um, and so then, after a while, there was a little bit harder time trying to get nursing jobs in the specialty that you wanted to work. Now with COVID, we see that a lot of the nurses have become burned out after the past 2 years. We've lost a lot of our seasoned, experienced nurses. So you see a lot of new grads working on the floor, and they don't have the mentorship from the nurses who have 20 to 30 years of experience. The work is quite labor intensive, if, as you guys probably already see, with just caring for one patient. These guys are taking care of 6 7 patients. They're working short. I know on our floor there's usually one aide for the entire floor, which means the nurses have to not only do the license part of the work, passing the meds, doing the IVs. They have to answer call bells and help out. So you go home tired. And it's, if you are, older, nurses are tending to, leave the facilities and retire a lot sooner, and work in a different environment. The shortage impacts the patient outcome and puts them at greater risk for errors, right? Um, Nursing shortages, nursing schools can't enroll students fast enough to make up for that change. And one of the things we are seeing is that I believe it's one of our sister facilities is going to go from just a night program. They're going to also open up a day program as well. So that can double the amount of nursing students that they push through. I wouldn't be surprised to see if they start fast tracking. Just as you saw people who wanted to become a CNA real quick, they didn't have to go through that specific training course. For 6 weeks, they were able to go and do that. Um, and we have student nurses going into the facilities and working now. Okay. Nursing instructor, yes, there is going to be a shortage of nursing instructors. The unfortunate part of education is that you can go work on the floors and you can make a lot more money as a new grad than you can as an instructor who's been teaching for 20 years. So that makes it a little bit of a challenge, and it also is a lot of responsibility and a lot of liability to take the students into the clinical setting. I feel like we do a lot of hard work to make sure you guys are competent and do well. So it's bringing you into the facilities is you guys work very hard and are highly motivated to succeed. So it makes it a little easier for us to bring you out there when you guys are proficient in your skills and stuff like that. We also want to try to get people from different schools at earlier ages to come into the nursing practice. By recruiting in the middle schools and the high schools, um, there are so many different jobs and careers available. Not a lot of people want to go into the nursing profession. As you saw at the beginning of COVID, first responders were considered heroes. There were hearts everywhere, everything to acknowledge all of the hard work that we do day in and day out. Nothing has changed. If it was snowing, somebody came to pick you up and you made sure you got to work that day. You don't get to call out sick for to take a personal day. You don't, because the patients are still there. If they all nurses needed all the time. So what I would like, think to help the nursing shortage, especially with instructors or with nurses, is to make sure that there's adequate staffing, the staff mentors the new nurses that are coming in, and then you see that there are some comparable wages there. I often laugh and you see, like they increased minimum wage to $15, and I'm like, oh my goodness, with all of the extra hours that I do, I, your salary is far less than that if you think about the average you wear it out. So I think they have to boost the working class salaries as well, and hopefully that will happen. And another thing is, if there's a shortage of nurse educators, increase the amount of funds and tuition reimbursement that is available for employees to advance their career. And so that's one of the things I would suggest to you guys is to, find out what the tuition reimbursement is and let the facility pay for your BSN or MSN and continue on with your education. Okay. Um, there is a case study that I have to go over. I have to go over the three other topics, so I'm going to save this to the end if we have some time. But you can read over the case study part 1 and part 2 on page 269 and 227, 2700. And you could we could go over that after if we have a little bit of time. So remind me that we didn't do that. And I'm going to move on to the nutrition lecture. Okay. Any questions about professionalism before we move on? Okay. Okay. So the next concept we're talking about is nutrition. The exemplar is going to be obesity. And this is a topic that is, something that hits home for me, as it's something, I talk about my father who struggled with his weight his entire life and how it's impacted his condition. And I feel like it's in my genes. So it's something that I too personally struggle with. So I find this one to be a good topic that I enjoy speaking about. Okay. As part of my research to prepare for this topic, I actually attended an in-service on bariatric weight loss surgery just to make sure I had some current information that I could share with you guys. And the one thing that really struck me, I guess I always, saw obesity to be a big, big problem here in the United States. and worldwide. But the way that they described it as a pandemic, and now that we have this COVID pandemic, it was like, oh my God, it is a big, big problem, you know? And the World Health Organization defines obesity as a condition of abnormal fat accumulation in your adipose tissue to the extent in which your health may be impaired. And we've learned about many conditions that might have developed due to obesity, right? And what kind of conditions do you guys think of when you think of somebody who is overweight? Diabetes, exactly. MI, HL, HLD, I'm not sure. Hypertension, yep.
Hyperlipidemia.
Hyperlipidemia, yes, yes, hyperlipid. That's what you're talking about, your cholesterol. Atherosclerosis, heart disease, yes. So many things are impacted by being a sleep apnea. Yep, your obstructive sleep apnea happens. Your mobility is impaired. Exactly. You have peripheral vascular disease, joint issues, yes, from having to bear the weight, extra weight, tissue integrity. Yep. Good. Very good. So it's a chronic progressive disease resulting in multiple environmental and genetic factors. So it can happen because of your environment, the way that you are brought up. And definitely, I think it's cultural too, with the way that you um, learn to eat and your different behaviors. That happens. Okay. So it is one of the most prevalent problems. So I recently saw a severe case of obesity and was very hard to see in person for the period. Yes, it is. You want to share about that, Kim? Or-
Yeah, so I work in the emergency room as a patient registrar, and
Mhm,
we had a patch come in for the patient who was having trouble breathing, and also she had wounds in her abdomen, but when they patched, they said she was 551 pounds. Um,
mhm,
so it took like 7 or 8 staff members to get her out of the ambulance and even to transfer her from the EMS stretcher to like the regular trauma or like for like the bigger bed for bigger patients. It
mhm,
was very difficult, and then she couldn't breathe. She was on the non-rebreather. um and then when they lifted her blanket, she had excoriation, like open little wounds all over her lower abdomen,
mm,
and they were not looking very well. They were suspecting sepsis. Because she lives alone, she was unable to walk. It was very hard to see.
yeah,
Like her
and
feet were
and
swollen. Like you can tell that her skin integrity was not very good, because even on the folds of her arms, there was breakdown. In her abdomen, there was breakdown in every crease possible. And then she couldn't even go to the restroom, so she was very irritated. Um, in like her private areas. It was
mhm,
very difficult to see because she has like a family and everything, but she says she lives alone, but unfortunately, it sounded like she can't take care of herself because of her condition.
mm. Yeah, and that's one of the things we're going to talk about. You brought up a lot of different things about the stretcher and stuff like that. We're going to talk about that when we talk about the bariatric surgery too, and the ethical criteria and some of the things like it makes me, as somebody who has a father who is obese, it is a very personal thing that I take personally when I see the nurses making jokes or treating the people that differently, like, oh, they're going to break the table, or I want to be paid by the pound, all these things that are just uncalled for anyway, is, because some of these conditions are genetic and you can do something about it. But it's very, very difficult, So
Yeah,
thank you for sharing that, Kim.
of course.
Okay, so pathophysiology, etiology, what happens is you're not able to, you not able to burn all the calories that you're taking in. So what happens is, if you're consuming more calories than you burn, it's going to be stored in your body as fat. And the unfortunate part is it almost becomes like a snowball effect. You develop diabetes, then you develop the neuropathy, then you have pain when you walk. And so, if I can't walk, how do I burn the calories? What do I turn around and do? So it does become very crippling and debilitating. Okay, hereditary may account for about 25 to 40% of the risks. And then there's the environmental factors. I learned to eat the way that I was brought up. I don't know if, you also think about the different types of culture. And I joke, when, because I am part Italian, our meals was a plate of pasta with a side of bread and more spaghetti sauce and then your meatballs, where most families will have a side, a little small portion of pasta as a side dish. So your daily meal. Yeah, oil and butter. Yeah, Robert, I think he's got some Italian heritage in him too, right? Or oil and butter for the bread, or both, right? And then we, also Polish. So we had, pierogies with everything was doused in butter. And my son has learned that as well. You also think about the emotional things and how you were brought up. Some people were, use food as a way to socialize. They use it as a way to show that they love each other, like, oh, I just brought you this cake. It's your birthday. We're going to have this. So that is, important. We also want to think about, society now with all of the technology. Kids are, always looking at their computers, gaming or doing different things. Um, they're not outside running around like they used to, not only with the technology, but how safe is it? I remember being able to go up and down the street and walk to my friend's house. Now DoorDash. Yes, DoorDash is a problem too. Yeah, that's a great, Sonia. um All right. So how do we prevent it? We need to start early on. And it's a big joke. My son has a little thing that he heard, and he says, if Bob has 30 candies and he eats 25, what does Bob have? And he says diabetes. Yeah. So we try to, we start at an early age, and my son will ask because he notices, Bob, why are you so heavy? And he'll say, well, because I didn't eat right when I was young, and you have to eat right too, and not just candy and stuff. So we try to, you want to put an end to that cycle that, happens. You engage in family style dining instead of making bigger portions. um, Educate the patients in all settings, and working with different health organizations to try to combat this problem. A lot of the schools now are also getting involved. I don't know if anybody else has children where they have to provide, healthy foods to the children. They're serving breakfast, lunch, and a snack, and all of them, should be of, fresh fruits, or healthier meal choices like low fat milk, things like that. Is, trying to instill some good healthy eating habits into the children at a young age. Okay, so what do we see with different clinical manifestations? How do our patients present? You will see that I have a picture there that you can either be a pear shape or apple shape, and the difference being where you store a majority of the fat. Okay, when you have more fat in the upper body, you have a greater risk for having hypertension, heart disease, stroke, your abnormal lipids, like Ryan had mentioned, and higher insulin levels. And when you have the pear shape in more lower body obesity, you tend to have less risk for heart disease or high insulin levels in the bloodstream. But it tends to be a little bit more difficult to treat. Okay. We're going to talk about the BMI. Did you guys talk about the body mass index? I think you did with Professor Dr. Murphy, right? The different parameter. Okay, good. So I'm not going to go over it, but here is a chart. There is a link here that you can check your own BMI. I'm not expecting you guys to be able to do the calculation to figure it out, but what you want to know is what's the range with what is underweight, what is a normal healthy weight, and what is overweight, and what is an extreme obesity. Because that's going to be important that you know the BMI, because that's going to determine your criteria for the bariatric surgeries. Okay. So what happens when we're obese? We have a lot of complications that arise. We have your heart disease, we have hypertension, high cholesterol, which leads to blockages or your MIs, right? Sleep apnea, and sleep apnea also contributes to the risk of heart failure. All right, you're going to see that a lot of members of the team have to work together to help instill healthy eating habits, exercise. So you might see, what type of team members do you think will be working with a patient who has obesity? Who do you think we would be calling in to help us? The dietitian, yep.
Nutritionist.
Mm-hmm. Physical therapy, social worker, yep. And there's
Even a case
a lot of,
manager.
What's that?
Case manager maybe for
Case-
resources.
Resources, yes, there you go. Good. You also want to turn around and not necessarily just rule out and things that you might not see is, somebody from mental health, like a psychiatrist or therapist, somebody to talk to them. A lot of times, I think somebody did mention comfort foods or using it as a coping mechanism, right? Family, excellent. Okay. The pulmonologist, yes, for sleep apnea, breathing problems. You're going to have your cardiologist for your heart disease, right? So you're going to have a lot of people working hand to hand. All right. So we can do a lot of different testing in addition to the BMI. The anthropometry is the measuring of the using those calipers to see how much fat that there is on a person's body. A lot of times you will see that people can be obese or overweight because they have thyroid problems. You're going to have them check the serum glucose because they might be developing diabetes. You're going to look at the cholesterol, lipids, and an EKG. All of the things that can help you to determine how this patient's condition is.
So that first test is the fat and muscle mass measurement, right? If I'm not mistaken.
Yep.
Okay.
Yep. You see the little caliper things in the picture? They use that and they actually will put it on the patient and it measures that information. Okay. Exercise, I think, is important. It's a critical part of losing weight. The theory is you have to be able to, burn more calories than you consume. Helps convert the body to lean muscle, mass instead of storing things as fat. And people, when they exercise, they, have a little bit of appetite, suppression. And people feel better about themselves. And, depression and anxiety, all of those things go hand in hand. And, if you don't feel good in your own skin, it's going to lead to depression for people. All right. So, a lot of the things that we are going to teach our patients about how to lose weight, what do you think we're going to implement? We're going to implement eating healthy, diet, exercise, right? Some of the things that we also can offer our patient is medication management. In the past, they have used a lot of appetite suppressants that have caused some heart problems. Anybody ever heard of the fen-phen, the Fastin and Pondamin that would cause the appetite, and the people were having a lot of heart. You already have a risk for heart disease already, and heart problems, and then you throw this medication in. Is this so? This medication here is different than that. This you will see now at Target or Walgreens or wherever else it is. It used to be by prescription only at 120 milligrams. As you see on the bottom, but now it's being sold as Ally uh, in 60 milligram tablets. So to get the prescription strength, you would just take two. But this is something that they have used to help treat patients who are overweight, and it works because it's a lipase inhibitor. It blocks the absorption of fat in your diet. Does that make sense? The diet and exercise and behavioral modification is helpful for when your patients have a are overweight. But once a patient has a BMI greater than 30 or greater than 27 with a significant risk factor such as hypertension or diabetes, you will see that they will start to recommend this type of medication or other medications to help a patient lose weight. Um, this medication works when you take it with food that have fat in it. If you're, eating a nice healthy diet, fresh vegetables, fresh fruit and stuff, and you take this medication, it doesn't have anything to block. Well, if you turn around and you go and you eat something like a French fries or fried clam strips or something, the medication is going to prevent the absorption of the fat, and it's going to be expelled from your body in that form. And so, although it sounds like a great medication, the problem is that patients experience a lot of flatulence and oily discharge from the rectum, and it's very urgent that you have to go, and it can cause abdominal pain. So sometimes they're not going to eat fats just because they don't want to experience some of these side effects. So it really does help a patient to lose weight, but sometimes they don't necessarily want to take it because of that side effect. When you take this medication, it not only blocks the fat in your meals, but it can block your absorption of fat soluble vitamins and warfarin. So some of the things that you are going to be looking out for is making sure that the patient replaces some of these fat soluble vitamins. And sometimes they maybe have to go, get an injection into the bloodstream versus taking them orally. Um, the warfarin is very important to know because you think about your patients who are obese, who have sleep apnea, right? They develop heart failure. They may have some irregular heart rhythms, so they're on Coumadin to prevent them from having a stroke, right? Well, if they start taking this medication and the warfarin is not being absorbed, these patients are going to be at risk for developing what? DVT, blood clot, and stroke, right? You guys, look at you. All right. Other thing, you guys, so how long are patients on this medication? They can be on it until they meet their weight loss goals. The one thing that can be important that the patients are aware of, and anybody who has any rapid weight loss, you are at risk of having cholelithiasis and needing to have a gallbladder removed. Okay. All right. So, oh, you're welcome. The dietary plan, we want to try to lower their intake of calories to make sure that they're taking about 500 to 1,000 calories um, less than they are consuming. One of the things that you will see is patients who have obesity do yo-yo dieting, or they have yo-yo weight loss where it goes up and it goes down. Sometimes I'm going to be very, very strict about this. Lose ton of weight and then they gain it all back, right? Um, this has to be a lifestyle modification in a way in which you lose, the weight over a long period of time, and you have to have a plan for maintenance. Oh, where did my thing go? Did I lose my picture? All right, you're still there? No, you see it? Okay, I don't see it. Yeah, please. Yeah, just go back to where we are. They can't see the chat. I'm going to try to, thank you. Yeah, you have to mute. You're an anonymous. Okay, thank you. I'm just trying to get my screen back up here. Stop sharing. Oh, here we go. I got it. All right. So the other thing is behavior modification. We want to teach the patients to have a food diary, so they actually see what it is they take. And I think Weight Watchers is one of these things where you have an app to track what you eat. And even myself, if I feel like I have to keep a daily journal of what I'm gonna eat and show it to somebody, it makes me a little bit more accountable. It also helps you to identify foods and things that you are eating, to recognize and actually just realize, oh my God, I am consuming a lot more than I actually, thought I was taking. And one of those things that I find very, very helpful too is now when you go to fast food restaurants, you will see that they put the calories up on the screen so you know how many you're actually consuming. Yeah, I remember being there one time. I wanted to have a Shamrock Shake so bad. I drove 3 towns over because the first 2 McDonald's didn't have Shamrock Shake available to me. And I got to the third one and I saw how many calories were actually in that Shamrock Shake and realized I could eat a 20-piece nugget for less calories than were in that, small Shamrock Shake. You laugh, Jake. I did actually go 3 towns to get one. But that's a comfort food. That was something that we had every February when my mom would come back from work. She would bring us a little treat. So it was something that I enjoyed. Anyway, there are some Hewitt too. Weight Watchers is a good way, in person. They also have virtual meetings now over at Eaters Anonymous, just like an AA or NA. Overeating can be a serious condition, and we're going to talk about that, the complications that can happen with that. And another support group is taking off pounds sensibly. All right. Lifespan considerations. We are going to see that, this is happening a lot younger. I just want to squeeze this little kid's cheeks and his arms. It's just so cute. But we are seeing that it's happening. Is that a real picture? I don't know. It's just something that I got off of the internet. I don't know who it is or anything to give the credits to. Um, so it can happen. If you stop and also think about it, we talked about gestational diabetes, right? And what did we say about the babies who are born to a mom who has diabetes? What do you think is going to happen? They have these very large babies, right? They're going to be big. It also puts them at predisposure for having hyperlipidemia, hypertension, and abnormal glucose tolerance later on in life, right? Good. And that's, we talked about that already, but I put it in here just so you could see the correlation between obesity. You're going to have gestational diabetes, insulin resistance, gestational hypertension, anemia, cardiovascular disease, and the mom is going to be at greater risk for C-section or preterm delivery. In your elderly patients, how are they going to be impacted? They're not going to be moving around as much, so they're going to have more adipose tissue for their muscle mass loss, right? And being obese puts them at greater loss of function and loss of independence. Okay, so how are we going to apply the nursing process to this concept? We want to make sure we teach our patients to start having a healthy lifestyle or weight loss throughout the lifespan, beginning at an early age, promote healthy eating, encourage activities, less sedentary lifestyles, and discuss the effects of smoking and alcohol with our patients. Our assessment is going to include your physical examination. You're going to, of course, look at the vital signs to identify risks such as, hypertension, your heart rate, right? You need to have very concrete data such as the height, the weight, measuring the skin folds, the hip to waist to hip ratios also can be very helpful. And we want to look at their skin. I think, as Kim said, it can impact the patient's skin, because they're going to be sedentary. Nursing diagnoses, these are some of the things that you're going to see. But note that, low self-esteem, knowledge deficit, activity tolerance, and ineffective health maintenance, that would be a perfect one for that patient that you were talking about because they can't care for themselves at home. Right? And even if they could care for themselves when you are obese, things in their environment are going to be, harder for them. Going upstairs, walking short distances and stuff like that. Okay, so we're going to come up with a plan, making sure that they know good, healthy choices, how much exercise that they should be doing, making sure that they attend support groups if possible. And then we have to evaluate, are they able to, explain what they should be eating, how much exercise should they be doing, are they working towards their goals? So you see some of these are long-term goals and some of them are short-term. But if you turn around and you say, oh my God, I got 50 pounds I have to lose, that seems so overwhelming and like such a big hurdle. But if you stop and you think about if somebody lost a pound a week and there's 52 weeks in the year, you could accomplish that in a week. So it seems to be a little bit more realistic when you form it in that style, in that state, I guess, or that way. So just as if your body weight, your BMI is, above 30 or 27, doctor's going to implement or suggest weight loss medications. And the other thing, did we talk about Ozempic when we talked about diabetes, the injection? No. Anybody see it on TV? Trulicity and Ozempic. I know by the song. Yes. All right. So Ozempic is a once a week injection that is used by diabetics to help lower their blood sugar. What what they have found is usually in your diabetic patients, they give them 1 milligram each week, and they have now found, that person will lose on average about 8 to 12 pounds. They are marketing Ozempic or Trulicity in a 2 milligram dose each week, and they are marketing it for weight loss. So that's another thing that you will see that they can do to help before they get to this surgical intervention. But the sad thing of it is if you're a diabetic your provider prescribes you Ozempic because you need it for diabetes, a lot of insurance will cover that. But the sad thing is that a lot of insurance companies consider weight loss surgery or other things such as this medication um, as Ozempic in a higher dose when you use it to lose weight. It is not something that they often cover. So it's kind of unfortunate that they don't see that the benefits of doing a weight loss surgery or providing this medication to help somebody lose weight will help reverse some of the complications that the person has had. Yes, that's shooting themselves in the leg. Exactly.
Well, because if they would just allow them to use it to treat obesity, it could stave off a lot of other health that would then require insurance to pay for. So if they would just allow it, they could save themselves money potentially.
Yeah, and that's one of the things that I was, share on a personal note. My dad had was always private, self. I don't know what you call it, an independent employer where he got his own insurance for his own company. And his insurance company wouldn't pay for this weight loss surgery. It was something like $35,000 or something ridiculous at the time. And now you'll see that more and more insurance companies are covering this surgery and not seeing it as a cosmetic surgery or something for vanity, but to see that there are benefits to doing this surgery. And had he been able to go and not be discouraged about he's afraid of needles or any type of scalpel. But had it not been so expensive and more manageable, affordable, he probably would have had the surgery. And would, not be in the condition that he is in now. Okay. In order to have the weight loss surgery, you have to meet a certain criteria. You have to be, stable enough to undergo anesthesia, free from addictions, such as drugs, alcohol, and smoking. One of the in services that I did go, the doctor said that he would not, perform the surgery on anybody who smoked, as the risk of dying from smoking was far more greater than having the weight loss, being obese. It takes a long time to go through the evaluation process to be a candidate for this surgery. They need to make sure that you are stable, that there are, of your sound mind. I'm not going to go to the next slide. You'll be able to, make the lifestyle changes that are necessary. Okay. So some of the criteria, and this is help, something that I would make sure that hint, 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 is that you need to know that a patient who has a BMI of 40 or more, or 100 pounds over ideal body weight, is a criteria for having this bariatric surgery. So this person would be a candidate. They lower the BMI requirement if the patient has one or more complications due to being obese, such as your hypertension, diabetes, congestive heart failure, or sleep apnea. Does that make sense? So you can just have a BMI of 40 and be relatively healthy, and you still can be a candidate. But they are going to be able to take a patient who has a lower BMI if they're already starting to show the complications. Okay. So the patient has to be able to tolerate and safely undergo anesthesia and the surgery, which will be done. Your patient is going to see a cardiologist. Your patient is going to see your pulmonologist, especially, sleep apnea is going to be, big. They're going to see a nutritionist, and they have to have shown documentation or be able to say that they've tried something else, um, and were not able to lose the weight, right? So maybe they've attended Weight Watchers in the past, or maybe they've tried a low fat, low sugar diet or something. Um, and they have to show commitment that they have an ability to lose weight prior to surgery. I'm not sure how much that is necessary anymore. I knew that was a big thing in the past. You had to show that you could lose X amount of pounds. It's individual to the patient. Okay, thank you, Sandy. But the last in-service that I went to, they didn't, specify if it was anything specific. Every time I've seen somebody that has weight loss surgery, they look much older than they are. Yes, and we're going to talk about why that might be. Okay. Willing to participate, you have to show that you're willing to attend these meetings with the registered dietitian, a nurse, the surgeon. A lot of people will also have to have a mental health evaluation, because sometimes when you remove the ability to, cope with, food as your coping mechanisms, they can develop other complications. Also, having these surgeries, if you're drinking, you can become intoxicated much quicker than you would if you didn't have the surgery because of the alteration in the metabolism. Okay. All right. So expected outcomes, what do we expect is going to happen when somebody loses weight? They are going to have more improved mobility, stamina, mood is going to be better, self-esteem, quality of life. And the big thing is that they reduce the risk of cardiovascular disease and other causes of mortality significantly. All right, in the bottom one, limit the number of current medications. A lot of people go off all of their hypertension medications, their diabetic medications, no longer need insulin because those are things that they have been taking because of being obese. So it is, like Ryan said, going to be, saving them some money in the long run. And I'm sure many of you have heard, like, what will you gain from having the surgery? And it is a lot of different things that you could not do prior to that. And watching, this really, strikes home with me, building something with your grandchild. It is so hard for my dad to even interact with my son. He can't go out and play a game with him. He can't toss them the ball. And he can't do any of those things by himself, without it being a big to do. Okay, picking out a new wardrobe, and that's something I'm looking forward to, is losing my my post-pregnancy weight, right? To be out and go buy something new or look nice. Taking a trip. So the point of this slide is that you will gain far more when you lose, if that makes sense. And there is a link on that bottom. Is an excessive skin a new issue? Yes. And we're going to talk about that on another slide as well. Okay. So there are different types of bariatric surgeries in which you can have. I don't expect that you guys to memorize how each and every surgery is done, what they're cutting, what they're connecting, and what they're doing. But what is helpful to know is the difference between restrictive, malabsorptive, and combination, and which one falls underneath each one of those. Okay. What happens in the restrictive is that weight loss is occurred because the amount of capacity that your stomach can hold is limited. So you're restricting the amount of food that your stomach will have, and you will feel fuller faster. Okay. One thing on here is the adjustable band that's not being done as much anymore. It used to be a thing that they did frequently, but now the surgeons are taking a lot of these bands out and are doing the gastric sleeve, and that seems to be the way that the trend is going now. You can also help a patient lose weight by doing a malabsorptive surgery. And in that, you're not able to digest the nutrients before they are expelled or passed. So you will see that that is a way that they can do it. I don't see that being done very often. And then there is the combination of restrictive and malabsorption. This used to be the gold standard. A lot of patients did have the bypass surgery, the Roux-en-Y, where they would shrink the amount of size that the size of the the amount of food that the stomach will hold, and then they also bypassed the path and um, inhibited some of the absorption of the nutrients. Okay. A lot of these surgeries now are being done laparoscopically. Um, they used to mostly be open. Now they have, improved the practice or the scale of how they're doing it, and they are doing it laparoscopically. Patients are in and out of the hospital much sooner than they were in the past. And then somebody had asked about the excess skin, and that on the bottom here is you will see that the cosmetic surgery is done to remove that extra fat tissue or that hanging skin. You could see that they might do lipectomy or liposuction. And the problem is that the excess skin after the person has lost the weight, removing that and it sometimes is going to be considered cosmetic and might not be covered. I don't know if that's been changed. All right. For those of you who like to know the why and the how, you can click on the blue link and open a hyperlink, and it talks about how the surgery is done and how it's performed. So I just put a picture of each of the different samples there for you to look at. So again, you don't need to know exactly how it's done. I'm not asking you to be surgeons or anything, but just to have the understanding. Like, so for example, I don't know if you see my little hand here. This is the vertical sleeve actually cuts a portion of the stomach and limits it. So it's working by restriction. This one, the Roux-en-Y, they restrict the size of the stomach, but they're also rerouting the way that the food goes. So there's far less digestion going with that one. You don't see my hand? Do you see the pointer? Yeah, okay, all right. Let me just click it here. Okay, so now you see with this is the vertical sleeve. They actually cut a portion of the stomach out and making the size of the stomach much smaller. In this one, the Roux-en-Y, the stomach is stapled across here, so the size of the stomach is small, but they're also going to divert the food and how it goes through the intestines to change the absorption, right? This one these are lap bands that where this with the sleeve and the gastrectomy, you see these are staples along the end. With the banding, they just put a pouch that can shrink the size of the stomach, and over here's a port where they would inflate the tubing around it to increase how small, almost like making a belt. It will make it tighter and restricting how much food can go through there. Sam, did you have a question?
Yes, for the one where they're doing the combo and they're rerouting it, how do you get your nutrients then if most of your nutrients are getting passed and not being absorbed?
So that's one of the complications, and somebody was saying people seem to look a lot older and stuff, is because you have a lot of nutritional deficits, right? These patients are going to be required to take a multivitamin for the rest of their life. Initially, especially when there's restriction, or like if there's a shrinkage of the pouch, their medications are going to have to be in a liquid form or crushed, right? Because you're not going to be able to take large vitamins. But they also have to take a lot of different medications, such as thiamine, folic acid. And I got one of these little handouts from that. And they talk about what type of vitamins they are going to need for the rest of their life. So it's going to be an ongoing thing that they have to do. The unfortunate part, and we're going to talk about it as well, is that you can, the B12 is one, calcium, fiber, are going to need to be replaced. And I think I have it on another slide. This is actually the image of them, stapling. Can you see my pointer? They remove a portion of the stomach and they staple it closed, is what I'm, guessing. And then they will remove part of the stomach. Okay. Some new and innovative things that they are using in addition to that, might be the intragastric balloon, where they put a balloon inside the stomach and they inflate it. You can right click on the link right here and see what it's about. And then they also have the V-block, which is where they use the neuroregulator to block, I guess it would be the sensation of being hungry or something. I'm not positive how that works. But if anybody has other, an interest in that, you can click on there just to show you that there are new technologies coming out. Okay. I've put some links to different hospitals. They have the information for weight loss at the different facilities. You'll see that the Hartford Hospital has a bariatric center. They do the surgery at Midstate, Bristol Hospital, St. Mary's, Griffin. But these are just a few links, so you can right click on them and get the information that you will need. Okay. Some complications of having gastric bypass surgery. The biggest one is, most common, I would say, is dumping syndrome. And I'll tell you about that. But as you will see, there's risk of death, blood clots, obstruction, all of these things that sound very, very scary, but they're really not any different than the risk of having a surgery. Anyway, you'll have that kind of complication. Some of the things that are specific to having bariatric surgery is nausea. So if you overeat too much, you can have bleeding, hemorrhage, shock, abdominal pain from peritonitis. So if there's any type of leaking, stricture is a narrowing or blockage. And since they don't do the lap band anymore, it's not that big, you won't see it as much. But when they put the band around the stomach, sometimes the stomach could go up above it or down below it. Or it can actually erode a part of the skin if it's too tight. Okay. big things we have to watch our patient for is hypoglycemia and dehydration. Okay. So what is dumping syndrome? Dumping syndrome is a rapid emptying of the stomach contents into the small intestine. So your patient is going to present with sweating, weakness, palpitation, and severe abdominal pain and diarrhea. Okay. You will identify this because the symptoms occur about 20 to 30 minutes after they eat, right? And why does it happen is if a person eats too much food like sugars or carbohydrates, or they drink with their meal. So the patients are going to be taught that they should not drink their liquids at the same time that they eat. Does that make sense? So by eating small frequent meals, consuming liquids at a separate time, and avoiding, a lot of carbohydrates and sugars, you can eliminate this dumping syndrome. So you want to make sure that you do know that that's the treatment and identify why. Okay. The problem, the problems that happen with bariatric, I had to drink when you couldn't eat. Yes. Um, the complications are malnutrition, weight gain, or not enough weight loss that's happening. The problem is like we talked about, what causes obesity is consuming more calories than we burn. So a lot of times what we see is patients will regain the weight back because you can go or bypass or trick your stomach to be, there's like get arounds. So they say you can't eat chips or carbs or a lot of food, but if you're drinking a coffee culotta from Dunkin' Donuts that's got 1,000 calories, it's not any different than having 1,000 calories of food of a different size or shape. So you do see that people can gain their weight back, and that's why they have to make sure that you're committed to losing weight. Okay. Nutritional deficiencies you are going to see, and you might want to go into your Adams book, chapter 43. It talks about the different types of nutritional deficits that you're going to see and the type of replacement. The most important thing for you to know for this is that if you're not taking enough nutrients in, you're going to see some of the complications. So in the same things we're going to talk about when we have our patients with eating disorders who are not eating, you're going to see the brittle hair, you're going to see the aging and just looking very drawn out and sometimes often too skinny because they did lose some of the weight. Okay. They can have pain, diarrhea, and vomiting. Pain management is going to be important for the patients. I want to make sure I have that somewhere in here when we get to it. Pain management is important for you to know that once somebody has their stomach modified they are at risk for bleeding, and they're at risk for significant reflux and other issues. So they cannot take any type of NSAID. So if a patient who has had bariatric surgery, they're going to be taking Tylenol and should be taught that they should not be taking any aspirin, ibuprofen, or naproxen or anything like that, because it can cause some severe problems. Okay. Hospital preparation, and this is one of the things I was thinking about when Kim was talking about that patient. You need to know what the patient's weight is, and you need to know what are the weight restrictions on these type of equipment. The typical stretcher can only hold about 250 pounds, right? So you can't just put a patient who is morbidly obese on the stretcher and not expect that it's going to be stable for them. We also want to be mindful and think about our patients who are overweight, and think about the body image and also their self-esteem. We don't want to turn around and say, "Oh, hold on, let me go get you a wide chair, or I'm only going to go get you the bigger wheelchair." We can just look at the patient and say, you know what, we need to automatically make these accommodations. We need to in use rooms that have a wider chairs and stuff. I know at Gaylord they have modified their rooms, and because if you stop and think about it, the normal door jams, if you think about a patient who's at home, they can't move around because their wheelchairs are going to have a wider base and they won't be able to fit through a standard door. Same thing with your wider stretchers. They're not going to be able to get in and out of the patient's room. So a lot of hospital facilities have modified their rooms to accommodate patients who are overweight. Okay. Even walkers. Yep, walkers, commodes, stretchers, blood pressure cuffs. So making sure that we just get the appropriate equipment for them, and having the right size chair. And it's funny because things that you never think about when you go to the doctor's office, they might not have wider chairs, or they put the cardiology office or physical therapy on the third floor, which makes no sense. As a nurse, we're going to do a lot of teaching. Teaching is going to be key for our patients, making sure they know lifestyle modifications. What do we have to do to change in our life? What type of dietary changes, exercise, smoke cessation? And we want to talk about the risks and benefits of having the surgery. Body behavior modification, talking to them about making differences in their behavior. All right. You don't need to know the difference between the different techniques. It's just there for you to kind of understand. In the hospital before they have the surgery, we are going to be doing a lot of monitoring, detecting, and making sure that the patient is stable, able to tolerate the surgery. Most of that should be done well in advance. They're going to do different blood work, get the vital signs, and make sure we identify any potential problems that might occur. After the surgery, patients used to go to the ICU, and when the gastric bypass was first started. Now I think many of patients go right to the medical floor. They're discharged within a day. They will be kept on NPO for a little bit, then start on clear fluids, then advance to high protein drinks. And then I did put a sample diet in here for you guys to see what it is that they will be doing. Again, here pain management is going to be important. They may have narcotics for severe pain, Tylenol for mild to moderate pain, right? But they should not be taking any ibuprofen, aspirin, or NSAIDs because it can cause ulcers. Teaching is going to require the patient know, what are signs and symptoms of dehydration, that they need to drink in between, report abdominal pain, increase exercise. And for women, it's important that they avoid pregnancy for 1 to 2 years. And antacids are something that they should take. Their diet is going to be advanced very slowly. So they're going to start off NPO, and then they're going to be drinking about 30 mLs or 1 ounce each hour. Then every 15 minutes, and then they'll work their way up to like a Carnation instant breakfast. Okay. No gum chewing, alcohol, straws, anything that starts with C, right? A chip, cookie, cracker, cake, carbonated beverage, ice cream, right? It sounds like it wouldn't be something for me, right? They got to drink 32 to 64 ounces of water to stay hydrated. all medications, and this is important for you guys, as you know, to know if your patient has a history of gastric bypass or a band or anything. Medications need to be crushed liquid or smaller than the size of a pencil eraser, so they don't get blocked. um, Patients with the back, with absorption issues and stuff, cannot have extended or sustained release medications. So you want to make sure you're doing a med reconciliation to see what type of medications they were on. If they were on a metformin extended release, or a cardiac medication that was suspended release, they're not going to go back on that suspended release medication after the surgery. The form must be modified. Okay. They're going to have a multivitamin and lifelong supplements of vitamin A, D, vitamin B12, folic acid, folate, calcium, and iron. All right. Can't drink at the same time, and they need to chew food slowly once they are able to move to solids. All right. This is a sample of their diet that they might have. Clear liquids are going to be on day of surgery. They're going to have 1 ounce of clear liquids per hour. Post-op day 2, they're going to have 3 to 4 ounces of clear liquids per hour. And then they're going to advance day 3 to 21. And why I put this here is not for you to memorize, but to realize that this person is not going to have, regular, even pureed foods until their post-op day 22 to 28. And then they're going to have calorie controlled diets after day 29. And it's basically only 4-ounce meals 3 times a day. So it is going to be very restrictive afterwards. No, don't memorize it for exam. You got it. See, I try to be subtle. Okay. Why do people regain the weight back? Because they find a way to trick the system, and they increase the calories that they need. They take in foods that are very dense in calories. We want our patients who are struggling to eat, who have issues with weight loss, that we want them to take in more calories. We want them to have the Ensure or the Miche, other drinks, because we want to get them a high amount of calories and a little bit amount of food, because they are not able to eat in a lot, right? They eat more frequently. They don't continue with the activity that they should have done. All right. So the one thing that I wanted to discuss again is, is obesity self-inflicted? Should healthcare providers provide this, or insurance providers cover these types of surgery? What do you guys think? What are your thoughts after we talked about this?
They definitely need to cover surgeries like this. And I think, there are plenty of instances where weight gain could be self-inflicted, but it could also be a product of emotional trauma, things like that. And it also could be part of your genetics and, the natural state of your body. And so I think, punishing people for this, it just goes against, it's not right to punish people for this, or to try and figure out what made them this way. It's just to treat them and try and make them better, in my opinion.
Yeah, no, that's a good opinion. Does anybody else want to share their opinion? Stephanie? Oh, yeah, Stephanie.
Yeah, I agree as well that it probably should be covered by insurance. I would want to see what the success rates are long term in terms of keeping off the weight, or is it just a temporary fix? I know my aunt had it years ago. She had the lap band, which is not really done much now, but she has been able to keep the weight off. But she has regained, and not to where she was, but she's still considered heavy. So I would want to see like more of the long-term, data on terms of diabetes, reversing, that, and also with heart disease and things like that. Some of the more hard facts, I guess.
Yeah, and I think even with the gastric sleeve or the gastric bypass, you can regain the weight, and that is something that is that is there, and that is something that does happen. Um, but when I think one of the data, I'll have to pull it up, was like there's only 1%. You know, a lot of people don't do it because they're afraid to die during the surgery, and I think like there was like only 1% chance of mortality with how much they did. And I think I scanned let me, if I look at, I think I saved some of that information from when I went through the in-service about that. Let me see if I saved it. Anybody else want to share their thoughts while I'm looking for this? So I think insurance now is covering a majority of the people to have it, as long as they're meeting the criteria. So I think that's really a nice change that I do see. And you know, something that's really important. How about gastric bypass for children or adolescents? Do you think this is something that we should do on young children? No.
I think it does. I think it depends on the age and the risk to benefit ratio. You know, if we're talking about an obese child who's 14 or 15 years old and they're starting to develop serious health problems that could, you know, lead to death or things like that, then that's definitely something to consider. You know, I'm not sure how I feel ethically about, you know, doing it to a 5-year-old or something like that. But, you know, if the evidence shows that they could die if they don't, then that's, you know, still something to consider, I think.
Yeah, I think I agree. And I think that a lot of the other people in the chat here agree as well. You know, that we did need to do some behavior modification and teaching and stuff like that. And they do need the nutrients to grow, as somebody did mention. So I think that's a great point. All right. Any other questions or concerns or thoughts on this topic? I know I went fast. I wanted to make sure I covered it all and I didn't give you guys a break. Anna, did you have a question?
Yeah, it was interesting to me when we saw the picture of the fat baby, how everybody was saying, "Oh my God, he's so cute. Oh, I just want to squeeze him. Oh, that's really all well and good when he's 6 months old, but then when he's 10, are we talking about surgery?" So maybe, you know, it's more educating us to not respond to a fat baby like that and think of him as a sick child or a soon to be sick child, you know. And I think for kids, the malnutrition aspects of it are far outweigh what's going to happen, you know, as far as hypertension and whatever. And it's about the counseling and the teaching him healthy choices, you know, addressing the underlying aspects of it, not just the end stage disease.
You're right. That's that great point, Anna. I mean, that's the kind of thing. It's cute when a baby is, you know, got chubby thighs. It's not as so appealing later on in life, you know. So I definitely agree with that, you know, as well. We also don't want the children to feel sick or ashamed either. Right? Exactly. Irina. Any great recommendations for studying? Well, I tried to give you the hints with the things that you need to know. Definitely want to make sure you know the prototype of the medication. I can't wink. I get Botox for my migraines, so my eye is numb, but I can try. Wink, wink. Definitely want to make sure you know the prototypes of the medications. How many questions from this lecture? I would say there will be roughly 3 from professionalism. You want to make sure you know the difference between the different organizations. The blueprint is up, yeah. The different types of organizations, about your, you know, your licensure, your state exam, what the NLN and the and just brief understanding what the Joint Commission is, and then thinking about accountability. How is it important, and how would you, apply the concept into your nursing profession? You're going to see some questions on obesity and the bariatric surgery. And then tomorrow we're going to have the concept of self and eating disorders. So you will see a total of probably 12 to 14 questions on the last these 2 days of content. Okay. If you have questions or you don't understand, put something in the discussion board, reach out to me. 11 on the blueprint. Okay, then that will be where it is. 11 it says. We tend to try to go, 2 to 3 questions per content hour. Yeah, makes 14. There you go. All right. Thank you everyone for being active and engaged. Your quick math is correct, Robert. You're welcome. Have a good day, guys.
Oh, you know what? Are you still there, Professor?
I'm here. Yep.
Okay. I'm not sure if I noticed if you mentioned it. What is the cutoff? What is considered obese again for BMI?
The BMI. Let me go.
Was that on the? I might have missed it. Or what is considered obese?
So on the calculator, it should be here. There should be, I think it was something.
Oh, I see. Okay. Yeah, I remember this. Okay. Thank you.
You should have it from the previous, I think, 18 to 22 was underweight, and something, I think 25 or something like that is going to be considered obese. More
over 20. It says 25 to 29 is healthy though, right?
healthy. Yeah.
Oh no, that's the green. Sorry, overweight is the yellow, and then obese is okay. Got it. Excellent. Thank you very much.
You're welcome. 20. Yeah, there you go. I think it's over 29 is overweight. And then they start the medication management when they are greater than 30 and 25. And then you have to be over 35 with complications for the surgery and 40.
Got it.
Does that make sense? So generally, when you start to be healthy to a little bit overweight, they're going to do your behavior modifications, eating, exercise. When you get a little, start to getting overweight, you're going to see that they'll begin to implement medication. And then when you're, morbidly overweight, they used to call it morbid obesity, but they don't use that term anymore. But the BMI, then they're going to 40, they'll do the surgery.
Great, thanks.
Yep. Anna, did you have a question?